So yeah, today I'm going to talk about diabetes in pregnancy, and just to give you an idea, so I don't live up in TRI here. I'm down at on the Gold Coast. So on the right hand, on my right hand, your left hand, so the screen there, that's Gold Coast University Hospital. It's also here, right? This is Griffith University. So I have a research lab somewhere in the trees here, pregnancy research group, and then I also hang out at in B Block, which is where maternal fetal medicine unit is at Gold Coast University Hospital. So Griffith and Gold Coast Gold Coast University Hospital are very physically quite closely located. We're also very structurally closely located as far as the research that I do. So the stuff I'm talking about now is really, again, what's the lines have enabled our group to do is take that basic research and start applying it or connect with the clinical side of things, which is where you can actually have impact. Because I trained as what I call a basic researcher, so I come through and I do things in the lab. I squirt stuff from this tube to that tube, and something lights up and I get very excited and geeky about it. But to get that into the clinic is actually, that's a process. So we find out things in the lab, it takes literally 20 years for it to get in the clinic, and that's not good enough. And so the other arm of what I do is, I'll talk to you today about the basic research, but also that just translational research, and that's what TRI is about, right? It's like making it so it's not 20 years. Like we can, if you know something's working in the lab, we can get into the clinic to benefit patients. So that journey is a really critical one. So that's where we physically are. And then, so diabetes in pregnancy. Like I say here, it's one of the greatest challenges to maternal and perinatal health worldwide. So maternal just over pregnancy, and perinatal just means around pregnancy. And a lot of that's to do with scale, right? It's 1 in 6 pregnancies now. That's a massive number of pregnancies that we're talking being affected. Almost 54,000 Australians will be diagnosed each year. And the numbers just keep going up. So this is one of the reasons that it's, that I focus on this, because it's just, it keeps becoming it's an ongoing issue that's just getting worse. And the reason the numbers are going up is varied. But it is things like now we're having babies later, we're bigger as a population, but then there's other stuff that we don't actually understand why those increases are occurring. Some of it's because we actually measure things now which we didn't used to. So that's 2011, I think, to 2022. And we started measuring things. We got a registry in 2011, and we've only got better at counting these things. So some of it's just that we know now. All right, so the reason gestational diabetes is such an issue, if we just look at the top there, it makes the pregnancy much more dangerous. So Dominic put up a slide where it said gestational diabetes and preeclampsia. So preeclampsia is another recession of mine. So that's hypertension in pregnancy with evidence of some other maternal organ damage. And I throw my hands around there because there are specific diagnostic criteria, but really it's a very general grouping of symptoms. So this is another, and diabetes in pregnancy that makes it much more likely that you're going to have that. A disease that thankfully not in Australia, but in developing countries that kills women. Right? It's very dangerous. So you're much more likely to have a dangerous pregnancy. And in Australia, we treat this, but we treat it by ending the pregnancy. Right? So that leads to preterm delivery. And for babies as well, like with gestational diabetes, you're much more likely to have a big baby, and they get fat mass in the wrong places, and that means they're more likely to have problems at birth. So birth traumas, they get the shoulder stuck. Actually, you're more likely to have cesarean sections, and there's a lot of ongoing issues around it as maternal and perinatal health. But I also want to point out that what goes on tour does not stay on tour when you're talking about pregnancy. Pregnancy is a massive stress test to a woman's system, and you're also growing a baby that will become an adult. So the things that happen then are really critical to the ongoing health of both of those people. And that also is an opportunity, because we maximise health in pregnancy, then we're maximising the health of 2 individuals. And I actually feel very strongly that we do need to do the best we can for people during pregnancy. So it's been an area, like cancer research, heart disease stuff there. You can put up some wonderful graphs that don't look like that diabetes graph I have there, about how we've made huge strides. I can put up, I haven't got them here, but I can put up graphs about things that have changed in obstetric medicine now flatline over 20 plus years. We're doing something wrong. So we've got to do better, basically. But yeah, during pregnancy, there's problems, but then after pregnancy as well. So specifically, just highlight here, both for the woman and for the baby, you're more likely later in life to have type 2 diabetes. So we're predisposing these people to having problems, that's a chronic problem later in life. And we don't know exactly why this is happening, but if we can maximise health through pregnancy, then that means that less likely to have these things. And so I highlighted this one because Happy World Prematurity Day. So I'm not sure you're supposed to say Happy World Prematurity Day, but yeah, today's World Prematurity Day. And I did just want to point this out. So a preterm delivery, they can deliver what, 37 weeks, and sometimes we have to have preterm delivery. Sometimes it's the best thing for the pregnancy, but to maximise health, we actually want to extend our gestation. So there's a lot of data now saying actually that up to a limit of around 40 weeks, it's better to extend that pregnancy. So some of the work I'm doing is really looking at how we can better map pregnancy health so that we can reassure the clinical team that it's okay to keep pregnancy going, because you do better as a child, with all other things being equal, which never are, if you can have a longer pregnancy. All right, so treatment for gestational diabetes. Now, the hallmark of gestational diabetes, just like type 2 diabetes, is high blood sugar. So really treatment is around controlling those blood sugar levels so they're at a level that's safe for mum and baby. And treatment, really, like other types of diabetes, is kind of in two tiers, if you like. So we start with lifestyle modifications. That's around diet and exercise. But that doesn't always work. If that doesn't work, then we need to move on to medication. For diabetes, so we're really talking about insulin and or metformin there. But the issue we have with this is that we test. So like type 2 diabetes, you've got a bit of time potentially to sort of try things out. If they don't work in a pregnancy, we're on the time frame, right? So we test for diabetes in pregnancy around there, 24, 28, 26 weeks. Very near the end of pregnancy. It's a very limited amount of time to be able to do anything. We're actually testing for, she's got the disease, by this point, she's got the disorder. So our ability to do anything is actually, to actually make beneficial changes, is very restricted. So you're fighting with pregnancy. So earlier is always better, but that's what we do currently. So the way to improve care is that because we don't know which woman is going to need medication. So if we can know that earlier, then we can give her what she needs at that point. And that's really what this project is focused about. So we can get the best care to a woman without delaying it, because in pregnancy you're just working to that timeline. Again, the earlier you can do things before she actually develops this disorder, then we actually have a chance of improving outcomes. And if we do manage to control women's blood sugar levels, it is correlated with improvements in a load of things. So all of those, that frightening slide I put up with all of that stuff, much, much better if we keep within appropriate limits. Okay, so when a woman has gestational diabetes, one of the big things that happens is you get more glucose, more sugar coming from her blood to the fetus, crossing the placenta. And that's what leads to things like a bigger baby, a macroscopic baby, and then we have things like birth trauma. But the other thing that happens in our group sort of focuses on is the placenta itself. So the placenta is the interface between maternal and fetal systems. It's my favourite organ. I think it's the most important organ you'll ever own. It takes every insult, it really does, to try and keep that pregnancy going. But it's a two-way system. So the placenta actually controls the maternal blood sugar levels. It's the hormones that it produces are part of what changes a woman's blood sugar levels during her pregnancy. And they're really important when it's going right for getting the right amount of glucose to a baby so it can grow. But damage to the placenta can happen in lots of different ways. I focus on oxidative stress, I'll mention that a little bit. And those insults can then, what our group is looking at is whether those insults are not just a cause of diabetes in pregnancy, but actually maybe, or not just caused by diabetes in pregnancy, but maybe actually a reason that some women are not responding to medication, a reason that some women have severe types of diabetes. So if we can learn a bit about the damage to the placenta and map that in a way, then we can, if we can map the function of the placenta, we can get a really good idea of how well that pregnancy is going. And I will just mention, I'm not going to talk about this, but I had to briefly mention it. Metformin crosses the placenta and gets to the baby. It also has effects on the placenta, so it changes stuff, mitochondria and things in there. And that's another, I've got a PhD student at UQ who's looking at that. So this stuff that I'm not going to talk about today, that's really important for just understanding what's happening when we're treating these women for pregnancy as well. All right, so I mentioned it briefly. So when we started doing this project, we thought that oxidative stress, which is stress caused to cells by free radicals, might have something to do with the pathophysiology and the development of the damage that's occurring in gestational diabetes, and specifically the skin in the placenta is what I'm focusing on here. We're now expanding that work to see how the placenta responds to that stress, and also how so how the placenta responds to that stress, whether that's correlating with the different severities of gestational diabetes, but also whether we can measure that during pregnancy, because I can't get a placenta halfway through pregnancy. Have a look at it, physically have a look at it. When we get a little upset, you can try that. All right, so what we've been doing is we take samples from women before they have gestational diabetes, before they have anything. So we get a lot of women that thankfully have very healthy pregnancies. But what we've been able to do is we take blood samples from these women, and then we measure various things. But to give you an example, we measure nucleic acids, so that RNA and DNA, specifically looking at RNA that Dominic mentioned. And what we've been able to see is that there are a set of expressed genes that in her blood that change before she gets around 12 weeks gestation, before she's developing any form of clinical symptoms of diabetes, in women that go on to develop diabetes in pregnancy. And it looks like those changes are actually related to how the body manages things like glucose and also placental function. So again, I'm not going to talk about nitty-gritty here, but there's a whole range of sort of cascades that we look at to sort of link these changes to what's happening in the placenta. And a subset of those genes also only change in women that then go on to require medication for their gestational diabetes. And so what that gives us is a way of telling early on, potentially, because that's what we're working on now, which women will go on to develop diabetes and which of those women will require medication potentially. So that's the dream really. So as far as improving care, like I said, those genes could lead to what we call biomarkers, right? Development of a new way to track what's happening with diabetes in pregnancy. And the goal is really to get a test that will give a woman and her treating clinical team insight into whether she'll develop diabetes, what the risk thereof, and with her likelihood for requiring medication. Because the earlier we know this, the better we can intervene. And there's a huge amount of evidence that says that, one of the big problems with obstetric care is really that we focus late on in pregnancy, because that's when all the problems clinically occur. But all that damage has happened earlier, so we need to know earlier so we can do something about it. And these are not these changes that we need to put in their lifestyle. They're optimising health. So there are things we can do. We do have a few specific treatments as well that help. But it's not, if we know it's not hard. And it also means that we don't risk stratify very well currently in obstetric care. So we tell women they're high risk, but they're not high risk as well. And then they have to go to hospital. They're with specialists. They don't really need to see who wants to go to hospital as well. So if we can also put low-risk women into a low-risk stream, that means that we're optimising healthcare, because a diabetic pregnancy costs about 25% more than a standard pregnancy. It's not complicated. So, and in a resource-limited situation, if you're spending the money there, you're not spending it in other places. So it's about optimising that. All right, I talked to you a little bit about this bit here. So nucleic acids, but what our group does is really look at a range of different potential biomarkers, because there's lots of places you can look for these things, right? So I say I, and I definitely mean we here. So this is Hannah and Cindy. It's Hannah in the front, Cindy in the back. So they're probably not right now for Sunday, but every other day I'm busy in doing this and pulling out different types of molecules and just looking at the same sort of principle. Can we see things changing? And really, it's not, I've talked to you about sort of a few things changing, but it's not, as far as actually getting this to the clinic, it's not so much about one thing changing. I think I chatted to some people last night about this at dinner. We really need to combine things. So if really about, for us, developing a tool that combines a load of stuff, and that's information about her Buxton's pregnancy, that gets put together with these biomarkers to be able to provide her with an idea of how her pregnancy is progressing. And that's really sort of what we're doing from a clinical translational side of things. It's getting a front end that a woman, this is what we've got money to do next year, can see on her phone the same things that a clinical treating things. And in obstetric care, there's over 100 guidelines. So in a busy clinical environment, a treating team trying to keep on top of all of those things is quite challenging. So just having something that can help people there. So it's all about sort of feeding into that. And it's really not something, it's a huge amount of work, and I'm just one person doing a little bit. But again, I'm just like, thank you to you guys, because none of this would happen without your support. And the continued support is, it's been fantastic. So just to sum up, what I'm looking at and what our team is really looking at is getting a deeper understanding of what's happening. Diabetes in pregnancy, instead of really we focus on placental health. And what we want is this personalised medicine approach. So again, Dominic explained it really well, because currently a lot of the time you come into hospital and everyone gets the same treatment, and it's regardless of whether that's the right treatment for you. There's a big push now in a lot of healthcare to get this personalised medicine approach where we really know what's actually happening, and that's part of what we want to do for obstetric care, because like everything, it seems to happen a bit slower for women's health and obstetric care. So we really want to focus that and try and be able to take the back end of all of the cool stuff we do in the lab, but be able to fit that in to something that's actually going to be able to be applied in the clinic relatively quickly. So we're developing something that has a front end where the back end can constantly be updated when more exciting new breakthrough research is done. So we can constantly change this. And I think, I just wanted to say thank you, and then to put up a few photos of the team, because this is absolutely collaborative research. So you cannot do research alone. So it's PP. It's not part of the lab, but these are my fantastic students. So we got Caitlin and Hannah and Hassini here, and then up here we've got a lot of the clinical teams, so